I'm going to do a short video today on peripheral vascular disease. I'm going to introduce the topic, but I'm going to go into it in depth to explain to people things that need to be treated and things that do not need to be treated. And I talk about this with some degree of consternation because one of the things I think that we tend to do is overdo procedures. For example, in the last segment of discussions, we talked about limb swelling and treatment for limb swelling based on causes, figuring out the causes and treating it. Well, I've seen so many cases where somebody will have leg veins I just saw one just the other day. Leg veins treated by specialists who should know better with ablation of the saphenous vein for limb swelling when the patient clearly had congestive heart failure. And that's not, ablation of the saphenous vein will not make a difference to congestive heart failure patients. Or they've been on medication like amlodipine at a dose of 10 milligrams daily, which increases the risk for limb swelling. So just because we can do procedures does not mean that they're the right things to do. I am on a kind of a website where vascular surgeons discuss cases and difficult cases, and somebody brought up a group of specialists who are going to nursing facilities and taking patients with limb swelling and doing ablations on their veins. That is just incomprehensible to me, that this kind of stuff actually happens. The same thing with peripheral vascular disease. Peripheral vascular disease, generally speaking, is a benign process. It does not need surgical intervention. It can be managed conservatively. There are very strong indicators for doing procedures on patients with peripheral vascular disease, and I will review them. And then there's other situations where I think it's perfectly acceptable to intervene surgically, even with minimally invasive surgery, for peripheral vascular disease. But there's far too many interventions being performed for peripheral vascular disease. And the problem is that most patients don't really understand the long-term implication of the disease process, and they also don't understand the long-term implications of an intervention. Anything that we do in terms of intervention carries risk-benefit analysis, not just in the short run, but in the long run. I mean, if you look at it through different filters, like the Ecolate filter, what are the words, what are the numbers, but more importantly, and then what? What's going to happen 5 years, 10 years down the line? So if we're going to consider any kind of intervention, we have to think about what's going to happen 5 or 10 years down the line. And then is there like a wide benefit, a disparity? Is it a convex lens or is it a concave lens that we see things through? Is the risk low enough and the benefit wide enough that we should do an intervention? These things have to be considered, not just in the short run, but in the long run. And then what? And that's where we, as interventionalists, don't really think through these things. And I dare say it's because a lot of us are based on what they call RVUs. The more we do, the more we get paid. And it's really disconcerting to me. I saw a patient that I followed for years with stable, what's called claudication. They have trouble walking long distances. When they exert themselves, they get calf tightness. This patient has had stable symptoms, and I've followed her for years and recommended that we do not intervene. Why? Because her lifestyle is not altered by her symptoms. It barely bothers her in terms of a normal activity level, yet that patient's cardiologist told her that she needed some intervention done on her leg circulation, when clearly she didn't. In fact, he suggested to her that she stop coming to see me because he could intervene and fix stuff. Complete and utter nonsense. And again, I'm not picking on cardiologists. There's vascular surgeons doing the same thing. There's interventional radiologists doing the same thing. But as patients, you have to understand why you're going through a procedure. What's the benefit of it? Is it worth the risk? Not just in the short run, but in the long run. Is there a significant amount of benefit relative to the risk to have a procedure done? And that's where I really think I'm going to spend a lot of time talking about the natural history of peripheral vascular disease, what to expect, how to manage it conservatively, and when you should consider intervention so that you'll be an informed decision maker and you'll have information outside of the clinics that you're going to be seen. Because I think that I can convince people to go through a procedure, but is it the right thing for you? And I think that's what you really need, that information to make that decision. But I will spend a lot of time on this starting tomorrow in a series of videos on peripheral vascular disease and how to manage it, the risk factors for it, the symptoms from it, what to expect in the short run and long run, how to treat it conservatively, are there any medications for it, what are the surgical interventions for it, what are the indications for surgical intervention. This is all pretty much standardized stuff now. Society guidelines are out there for managing this stuff, but I will tell you that there's a lot of procedures done that do not follow the society guidelines. Not just in peripheral vascular disease, I just saw a publication the other day on aortic aneurysm repairs, not following standard guidelines for procedures performed for aortic aneurysms. I will get into all of this stuff in later videos.